Peace. Welcome to the YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. I'm your moderator and narrator, Uriel Riley. Welcome you to Chapter 4, or Section 4, Airway Care. This is the introduction to Section 4 of this book. We're doing it. We are doing a wonderful job reading this. Thank you so much. So this is the beginning of Chapter 15, the artificial airway. All right. Peace, highest heart, love. Happy Friday. It's been a wonderful day. I got to go office. We had a Uriel session yesterday. We went over 450 diaphragmatic breaths in the session. It was just unbelievable. All the blockages that his hand finally opened up, and I was just getting them out. It was just crunches everywhere. Oh my goodness, healing the people. We're doing the work. And that's why we come here to this peaceful part of YouTube where we read books and learn from masters. So, highest heart love, thank you so much for being here with us. Because when we heal ourselves and master ourselves, we can help others heal. That's the goal. That's the whole purpose. Here we go. Chapter 15 of Clinical Application of Respiratory Care. Page 235 at the top. This is the start of Chapter 15. The first principle of resuscitation and life support is assuring a patent airway. In the absence of an adequate airway, the pulmonary system is incapable of appropriate gas exchange. Nothing is more crucial in intensive respiratory care than the appropriate assessment and management of the airway. The medical specialty of anesthesiology has thoroughly studied and evaluated the techniques of airway establishment and maintenance. The respiratory therapist and respiratory nurse specialists are the non-physician healthcare specialists responsible for airway care in the modern hospital. In the emergency room, recovery room, and intensive care unit, these respiratory care practitioners must be competent in all areas of airway care. The overwhelming importance of the airway in acute respiratory care and critical care medicine makes a thorough understanding of airway management essential. Yeah, peace. Welcome. Thank you so much for reading with us. All right. Upper airway obstruction. The upper airway obstruction may occur from two sources: soft tissue obstruction and laryngeal obstruction. The most common airway emergency is soft tissue upper airway obstruction. This phenomenon is caused by the soft tissues of the pharynx impinging on the patency of the upper airway secondary to the pharynx, secondary to 1. The loss of muscle tone from CNS abnormality, e.g., the unconscious patient. 2. Space occupying lesions, e.g., edema, bleeding, tumors. Or 3. Foreign substances, e.g., vomitus, false teeth, foreign bodies. The common factor in all soft tissue upper airway obstruction is the lack of patency between the base of the tongue and the posterior wall of the pharynx. Figure 15.1. The recognition of upper airway obstruction depends upon close observation and a high index of suspicion. Partial upper airway obstruction is usually accompanied by noisy inspiration that sounds like snoring. This noise is usually limited to inspiration and is of a low tonal quality. The greater the obstruction, the louder the noise. Complete upper airway obstruction is accompanied by marked inspiratory efforts without air movement, marked sternal, intercostal, and epigastric retraction is usually present along with strong contraction of accessory neck muscles of ventilation. If conscious, the patient will be obviously distressed and extremely anxious. If unconscious, the patient may appear dusky, and the ventilatory attempts may become so violent that they appear to be seizures. The treatment of soft tissue airway obstruction is obvious. Relieve the obstruction, right? This should be accomplished with the simplest maneuvers as possible. All right, here we go. 15.1. You have a display right here of the upper airway obstruction caused by soft tissue. So you'll see the tongue, the epiglottis, the trachea, and the esophagus. Page 236 of chapter 15, Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Second edition. Thank you so much for being here. Hi, it's Heart Love. Hi, happy Friday, Dad Blends. Hi, it's Heart Love. Rule Face. Much love. Thank you so much. Yeah, the peaceful part of YouTube where we read books and learn from masters. So thank you so much for the likes and subs. We're pushing towards 1,000 on this quiet part of YouTube where we read books, reading books, you know, giving something back to the youth. And so this is information of self wisdom, self knowledge, anatomy, so on and so forth. So when we master ourselves, right, we're mastering our world. And when we can heal ourselves, we can help others heal themselves. So this is what the purpose is, the mission, right? Continue to read these books on YouTube. Thank you so much. All right, so neck extension and chin manipulation. The process of neck extension and elevating the chin, figure 15.2, is effective in relieving soft tissue upper airway obstruction. This should be the first maneuver attempted. The unconscious patient can often be moved into a lateral position with neck extension so that gravity can clear the soft tissue obstruction. The lateral head position allows the tongue to move forward and open the airway. The mouth must always be inspected for foreign bodies, even after obstruction has been relieved. Okay, and so here's a figure of placing where you want to place the neck and head for extension and elevating the chin. Okay, 15 figure 52 15.2 says clearing of soft tissue upper airway obstruction by the neck extension and chin elevation. So you see that down here at the bottom. Gratitude for the shares and likes and comments. Highest heart love. Thank you for being honorable in the Imbangi. Much love to all the YouTube book readers and book lovers. See, there it is at the bottom. See? Okay. Excellent. Excellent. Here we go. Oropharyngeal, oropharyngeal airway. An oropharyngeal airway is a device designed for insertion along the tongue until the teeth and or gingiva limit the insertion. Figure 15.3. The device lies between the posterior pharynx and the root of the tongue and thereby maintains a patent airway. It is designed so that a suction catheter can easily be passed to the laryngopharynx. This type of airway frequently causes stimulation of the oral pharynx and will activate the gag reflex if intact. Thus, an oropharyngeal airway is well tolerated by an unconscious patient. But as consciousness returns, the stimulation of this airway may produce gagging, vomiting, and even laryngeal spasms. In general terms, the oral pharyngeal airway is adequate for comatose patients only, and usually for limited periods of time, which is very key, right? Okay, and so here's 15.3, the oral pharyngeal airway. And this is the device, right, that just slid into, like it was saying, into between the tongue. All right. Thank you so much for reading with us. Love to all the nurses and aspiring doctors and physicians and respiratory techs. This is for you. All the people taking NCAT, given to thousands of dollars of information in this book for free, live here on YouTube. That's how you know we love you, right? It's the real deal. All right. Yeah, this book was $3,500. Yeah, it's the real deal. Hard hardback edition. All right, so says the oropharyngeal airway. See test. So here we go. On middle of page 237, the nasal pharyngeal airway. The nasal pharyngeal airway is a soft rubber tube constructed so it can be inserted through one of the nares and follow the posterior wall curvature of the nasal and oral pharynx. Figure 15.4. Its terminal portion is positioned at the base of the tongue, separating it from the posterior pharyngeal wall. Upon insertion, the nasopharyngeal airway may create bleeding, which can be minimized if the tube is lubricated well. The advantage of the nasopharyngeal airway over the oropharyngeal airway is that is it is much better tolerated by the semi-comatose and awake patient. In general, patients can better tolerate stabilized nasal airways that lie on the posterior pharyngeal wall than those inserted through the mouth. The nasopharyngeal airway provides an adequate means of preventing or relieving soft tissue upper airway obstruction in the semi-comatose or alert patient for reasonable periods of time. Adequate suctioning of the pharynx is possible with an appropriately lubricated suction catheter passed through the airway. Even though the tube is flanged, a large safety pin placed at the outer tip or even taped to the side of the face will assure that the tube will not slip entirely into the nose and down into the larynx. Top of page 239. Well, let's look at the nasopharyngeal airway with the device and how to slip it in. Thank you so much. We're giving you all the gems. Highest heart love. Here we go. Clinical application of respiratory care. We just entered the 15th chapter and the fourth section of this book. So thank you so much for reading here with us, all for free, live from the light. You see that? You slip it in there and it takes the form, right? And that way you can suction out, right? Okay, because we're in the artificial airways section. So thank you so much. Oh, well, we're going to pray for you. And we all always sing I love you at the end of this. So anyone that wants some healing energy, you know, this is the place for it. We're master healers on this channel. So thank you so much. You know, we're all about the people and uplifting the people and reading to the people. Much love. Definition of artificial airways. When the simple maneuvers just described are not adequate for relieving soft tissue upper airway obstruction, the establishment of an artificial airway must be contemplated. Although there are a variety of opinions about the exact definition of an artificial airway, we define it as a tube inserted into the trachea that bypasses the upper airway and laryngeal structures as integral parts of the total airway. In essence, we mean the establishment of an endotracheal tube or a tracheostomy tube. Accepting this definition, it is obvious that an artificial airway will relieve soft tissue and laryngeal obstruction, protect the lower airway from foreign body aspiration, and provide an easily accessible route for artificial ventilation and tracheal suction. Indications. Since the establishment of an artificial airway is a serious step, the decision to do so cannot be made without rationale. It is essential to delineate definite criteria for establishing an artificial airway. Indications for establishing the airway may be divided into four categories. One, the relief of airway obstruction. Two, the protection of the airway. Three, the facilitation of tracheal suctioning. And four, the facilitation of prolonged artificial ventilation. Relief of airway obstruction. The middle of page 239. The establishment of an artificial airway guarantees the patency of the upper airway regardless of soft tissue or laryngeal abnormality. Yes, that's right. Protection of the airway. The pharynx, vocal cords, and epiglottis play an important role in protecting the lower airway from aspiration of secretions and foreign bodies. These normal airway protective mechanisms are essential for the clinical evaluation of airway protection. There are four main airway protective reflexes. This is very key. Here we go. Connecting another dot. Ding! One, the pharyngeal reflex has an afferent limb, sensory component, nerve, right? This is very key. Check this out. In the as a sensory component in the ninth cranial nerve and its efferent limb, motor component in the 10th cranial nerve. Ding! The vagus nerve. This reflex arc is responsible for both gag and swallowing reflex. 2. The laryngeal reflex, neurologically described as the vagovagal reflex. Afferent and efferent components are vagus nerves, will cause apposition of the vocal cords, laryngeal spasm, and an associated closing of the epiglottis. 3. The tracheal reflex. A vagovagal reflex causes a cough when foreign body or irritation occurs in the trachea. 4. The carinal reflex. A vagovagal reflex causes a cough with irritation or of the carina. Page 240. The protective airway reflexes are obtunded from the top down, i.e., first the pharyngeal reflex, then the laryngeal reflex, and then the tracheal reflex. This is true in all circumstances affecting depression of the CNS, whether by anesthesia, drugs, disease, or general loss of consciousness. It is extremely unusual for the carinal reflex to be totally ablated, since this reflex persists to the deepest level of the CNS depression. Thus, one would expect to obtain some type of rudimentary cough reflex from stimulation of the carina, even in deeply comatose patients. Thank you so much for reading. I know it's a lot. I put into each um, reading, you'll see in the description, I will put the vocabulary so that you can look up some of these words. If you're having a tough time identifying them, you'll be able to look at it and look it up, vocabulary in a glossary, and so it can make more sense for you, because anatomy is a lot of heavy stuff. So hi, it's Heart Love. I just appreciate you all joining and reading in with us. It's high level stuff, but that's what masters are going to be mastering for, right? So we can do it, give it to the people, and then they can master it. So thank you so much. I'm Master Fitness Trainer by trade, Uriel Neville Riley, trained athletes all around the world, pro athletes, as well as I created two healing modalities that I use to help heal the people. So we're with the light workers from the Imagine Center, and we're here, right, to help heal the people. The angel lights on earth. Thank you so much for being here. All the earth angels, we love you. When an individual awakens from general anesthesia or recovers from a state of unconsciousness, the airway protective reflexes will resume appropriate functioning from the bottom up, i.e., first the tracheal reflex will return, then the laryngeal reflex, and finally the pharyngeal reflex. The establishment of an artificial airway is indicated whenever an individual cannot protect the lower airway due to alteration of the airway protective reflexes. This is an important indication for establishing an airway, since the most important element of supportive care in many disease states is to establish an airway to protect the lungs from aspiration. See chapter 33. Hi, it's Heart Love. Thanks. I was wondering what page we were. Thank you so much, Matt CC. Hi, it's Heart Love. Yes, we're in the middle of page 240. Okay, gratitude and highest heart love. I love you so much, Matt. I'm gonna have to the next one, especially if you get to make it on time. I'm gonna make you a mod. Thank you so much for your support, your continued support, and your knowledge and information on the subject. And we love to help the healers, you know, and mastering more ways to heal than one is how we really become a force in the world, right? So, like your healing, I put together multiple modalities and start with the diaphragmatic breath, right? So, respiratory care. And that's why I had so much a great concept of the information. And then I put it with assisted stretching to all the major muscles in the body, right? And then with reflexology to the hands and to the feet, because that's why our hands and feet look different than every part of our body, right? And that's because that's where the nerve endings are. So combine those three modalities together to give you your healing. And the harmonic vibration the same way with the voice frequency resonance. So this is our goal, is to just continue to create more and more healers all through and light workers all through the world and form this network. So we honor you so much, Matt CC. Highest heart love. We're in the middle of page 240. Here we go. Facilitation of suctioning. There are numerous disease states in which the patient's bronchial hygiene mechanism is inadequate. There are numerous methods for mobilizing secretions to the trachea, but mobilization from the trachea to the pharynx requires either an adequate cough or direct suctioning of the trachea. Yes. Although it is possible to insert suction catheters via the nose or mouth into the trachea, this is not always effective and can become an extremely traumatic and time consuming process. In many circumstances, it is essential to establish an artificial airway for the purpose of facilitating removal of tracheal secretions by direct suctioning. Highest heart love, Mia, Youssef. Awesome. Shukran. Much love. And we'll pause right here in the start of chapter 15. The mods are in the building. Yes. Youssef, Matt CC, highest heart love, all the light workers and healers, nurses, reps, techs. Here we go. We're doing it. We are now in chapter 15 of clinical application of respiratory care. Yearbook Medical Publishers, Inc., 1979, second edition. We have just entered a new chapter. Thank you so much for the likes and subs. We are shaking it up on YouTube, reading books, medical, high level vocabulary for all the light workers unite, right? Let's have a glass of love water, right? When we reconvene with chapter 15. Love you so much. Thank you for all you do in the world. Thank you for providing the light. I want you to have a wonderful day, right? Have some love water. Sing I love you. Live from the light here in LA. Always for the people. Love you. Mm. I love you. I love you. I love you. Thank you so much. Yay. That's what we want. We want to be able to heal ourselves and to heal others around us. which is like the highest form of love, right? Is wanting the best for one another. I love you so much. Thank you for everything you do. Highest heart. Yes, lavender. I love lavender and hibiscus. Yes, that's right. Disabled veteran. We're doing it. Oh my goodness. In the love water, I have some hibiscus. Awesome. You know what? We're going to keep doing this work. And thank you so much for being here. I love you. You know I do. I love Miley too. I don't talk about a lot of celebrities because, you know, um, I like to focus on the healers, you know. So I love all the light workers and love to all the birthdays of September 19th, right? All the Virgo energy. We love you so much. Highest heart love. I love you. You know what? You know. We love you too. All right. I'll see you soon. Peace, peace. Highest heart love.